the same. And I usually, because people seem to come in with a preconceived idea just through their own internet search as to what the issue is. I'm coming in for a thyroid issue. I'm coming in, I think my hormones are out of balance. And I always have to take a step back, not only just to look at the bigger picture of functional medicine, but also within hormones to talk about how hormones are used by the body. And that starts by, the hierarchy of where is the priority. So, we always start there. And the beginning of all of these pathways begins with adrenaline. People have heard of this as the fight or flight hormone. And if you're getting by a bear in the woods, if you're with a coworker, that's adrenaline. That feeling, people have experienced it, they know what it feels like. But when that happens, every other system shifts to support the production of adrenaline. It's short term, it resolves fairly quickly, but that becomes the number one priority for obvious reasons. It's a survival hormone. The next one down is cortisol, and cortisol is a little bit more of a long-term response, where adrenaline, it peaks and it comes back down pretty quickly. Cortisol peaks and then it has a little longer latent phase. So you can have multiple peaks over time. And so sometimes you never get full recovery of cortisol. And so when there's a stressor, and I usually, there's multiple different types of stressors. We think of cortisol with lifestyle and emotional stressors. However, things like physiologic stress, infection, inflammation, food sensitivities, chronic pain, liver and kidney dysfunction, all of these things are physical stressors by the body. The body is constantly trying to support that, and that's where the bigger functional picture comes in. But when cortisol demand is high, everything downstream suffers. Mm-hmm. So one of the first things I have to look at is, what is your stress level? Most of us are in stress. For some people, when you ask the question, how do you tolerate stress? Can you handle it pretty well and keep yourself calm, or does stress in general make you, does it feed on itself? Does it build and build and build and build to the point that you're anxious and you can't sleep and you're tense, you can't think clearly? So when I see that that's a big issue, you have to talk about cortisol first. So when you talk about cortisol, my first question is, what do you do in response to stress? The amount of research on cortisol and the stress response and every physical condition, every illness, there's research on the stress association. And many of my patients have heard me give these examples because they're kind of my favorite, but there's actually been studies where they look at cortisol levels before and after laughter, for no reason. You can actually bring your cortisol back down just by bursting out laughing. There's also a really cool enzyme that when you meditate, the enzyme rises, and that enzyme helps pull hormones away from the cortisol pathway into your androgen pathway, which is more of a growth and healing pathway versus a wear and tear cortisol pathway. So there's a lot of research on what cortisol does and how we can manipulate it. We have so much more control than we think. And I always like to tell my patients, stress is not something that happens to you, it's how you respond to it. So that's where you have to start doing the work. You have to start looking at, how do I respond to stress? Is it meditation? Do you do meditation? And do you find, multiple times during your day to try to bring that cortisol response back down, even if it's just stopping, laughing, and visualizing it coming back down? But you have to start someplace. And I can't really counsel people on that because it's different. What works for one person may not work for another. So you have to start with some of the basics. So when people say, yeah, I can't just sit and meditate, I can't just sit and focus on my breathing. One of the suggestions I make is, why don't you just set your alarm 10 minutes earlier? Hit snooze once, lay on your back, close your eyes, put your hand on your abdomen, and start practicing how to, breathe abdominally, not with your chest, but with your abdomen. There's actually, when you breathe that way, there's pressure on your diaphragm from below versus from above when you breathe with your chest. And that vagal nerve goes right up to the brain and helps you release GABA, that calming neurotransmitter. So just by changing the way you're breathing is going to help. The other thing is if you are somebody who only tries to change the way you breathe when you're under stress, it's kind of like trying to run a marathon without training. It's just not going to work. And your brain is just going to get confused. So it has to be something you practice every single day. So when you do change your breathing, okay, I'm under stress, so I'm going to start breathing with my abdomen. I'm going to do the old count to 10. Your brain isn't trying to go, well, what are we doing now? I don't really know. We're under stress. So it has to be something that you practice. For some people, then taking it from there, some people will listen to podcasts, that are about, where you're having somebody talk to you about meditation. For some people, it's prayer. For some people, it's listening to music. For some people, it's going for a walk. For some people, it's just sitting quietly and breathing and looking out the window. It can be very different for every person. So you have to keep making the work to figure out what's going on. I can't hear you. No.
There you go.
Now I can. Could you hear me?
Yep. Got it.
Okay.
So to stop right there, talking about the breath, I really, I love that because, I've been doing some different trainings and have really kind of been training for hypnotherapy. And it's been really interesting to, helping that person go down, deeper and deeper is releasing the diaphragmatic breathing. And I think at any point in time, it's a really, really easy way for someone to contract at that moment, breathe diaphragmically. And have you heard of the 7-11?
I don't think so.
So you're going to breathe in for 7.
Oh, yeah.
And
There's
then breathing out for 11. There's all kind of different count metaphors.
Yeah, there's square, there's in for 7, out for 10. I've heard lots of different ones. Yeah.
But the vagus nerve, to what you were saying, I've also heard is the actual creates the access between the brain and the gut.
Yeah.
So even thinking about stressful times in eating, stressful times and, how women are often tense in their gut, irritable bowel, it's like where are those messages really coming from? So I think that, just stopping on breath work in itself is really, really powerful.
Right. Yeah. No, and it is, you have to start someplace, and just focusing on the breath is the best way to do it. But then how, I've actually had people that have told me that anytime I try to meditate, I start to itch. It's just a constant distraction. Something is constantly pulling them away. So it has to be something you really practice. It has to be unique to you. It has to work for you. So I can give, information to patients on, how to get started, but then you really have to take it from there to figure out what is the best practice for you. And you have to commit to it, and you have to, schedule it in your day. It's not like it takes an hour. It can take 10 minutes at the beginning of the day, 10 minutes at the end of the day. But it really does make a difference. And using meditation then gets me into my next thing about cortisol is when you have somebody come in and they're not sleeping, really trying to focus on, and there's reasons why they're not sleeping that you have to focus on, but when somebody isn't sleeping, what is the best way I can get them to start getting sleep and rest? Because if cortisol is an issue and they're not sleeping, it's just a feed forward system.
Right.
So that is one intervention, is how can we get you sleeping better? And there's lots of things, that can be used for that, from herbs to CBD to neurotransmitter support, melatonin. I mean, there's lots of different options, and I usually kind of make that decision based on, what are the other factors going on. But intervening at that point to try to make sure people are getting good quality, restful sleep. And if it's frequently interrupted, what are some things that can be done to try to get people into those deeper phases of sleep? And I actually heard at a conference a few years back, there was a discussion about, it was a study where they looked at people using different, they were studying people that were doing shift work. And what they ended up finding out is that really, that the shift work people have a lot of trouble, because if you're sleeping during the day, we all know that the health issues associated with that. But between 10 p.m. and 2 a.m., all of us get the majority of our stage 4 sleep.
Hmm.
That's our recovery sleep. So if you're going to bed at midnight, you're already losing 2 hours of
2
really
hours.
rest. So if you can get yourself to bed and start calming and turning your electronics off, a little about 8 o'clock, and try to get to sleep by 10 o'clock. And then if you can get a really good solid sleep between 10 and 2 a.m., you're already doing pretty well. And then from 2 to 6 a.m., you're going to have more interrupted sleep. And maybe you're not even waking. Maybe it's just where your sleep cycle is coming a little closer to the surface. But if you wake up, 2 to 6 times a night, but in that 4-hour window, but you're able to get back to sleep pretty quickly, you're still getting pretty quality sleep. So looking at sleep is one of the next things with cortisol. And the other thing is, we all know if you have a few drinks before you go to bed, you're probably not going to sleep as well. If you drink caffeine too late in the day, you're not going to sleep as well.
Right.
Eat too late, you're probably not going to sleep as well. So looking at the timing of your meals and alcohol consumption and caffeine consumption is really important. But all of those things, can be done on your own to look at cortisol, maybe down the road, we'll talk a little bit about, how I would intervene. But I just want to say one thing about cortisol is, sometimes people come in and they say, I know I'm having a cortisol issue, or I think I have adrenal fatigue. I have to say, in 12, almost 13 years of doing this, I don't see adrenal fatigue a lot. I mean, it is happening, but I see a lot more stage 1 and stage 2. Stage 1 being a hypercortisol situation, and I see that a lot comparatively to adrenal fatigue.
So can we just stop right there for a second?
Yeah.
So in the functional medicine world, we hear the term often wired and tired, right?
Mm-hmm.
So there's this range where you can be in where you're completely adrenal fatigued, and I think that's, just to clarify, that's what you're talking about, is that when you've gone through all the stages, being wired and tired, and you've kind of you've totally stressed out your adrenal hormones, and you are at that point of adrenal fatigue, that there's this place where you're kind of excitatory, you're in a state of inflammation, and you have high cortisol, but you're not indefinitely at that point of like clinical adrenal fatigue. And people women walk around tired all the day. So they just have this soundbite, I have adrenal fatigue, correct?
Right. Yeah. And that's kind of you hear that term a lot. The actual true term is adrenal insufficiency.
Yeah.
But stage 1 is really more of a hypercortisol situation. Your body is demanding a lot of cortisol, and it's producing a lot of cortisol. So as we talk about this hormone hierarchy, this is really what we're referring to is when your hormones are demanding so much cortisol, it's taking resources from the other hormones.
Exactly.
The stage 2 is, I like to call that the sputtering engine. It's kind of like it's up, it's down, it's up, it's down. You're kind of in that transitional phase where, yeah, I can make more cortisol. No, I really can't. Yes, I can. No, I can't. And that's kind of that transitional phase. And you see that occasionally too. And then the adrenal fatigue is when we're not even really seeing a response. The adrenals are just not able to produce. And there's a lot of I've seen real severe cases of that where people can't even make it through an hour office visit. They have to leave. They get nauseous. They get anxious. And we have to finish up their visit over the phone. But I can't say I've seen it a lot, but I have seen it. So it does exist. But most patients that think they have adrenal fatigue or adrenal insufficiency are probably in another stage. So you have to be a little careful with just throwing random, supplements at it, because supplements are for calming cortisol and some supplements are for raising cortisol. And sometimes you need things at different times of the day. So the best place to start when you're trying to work on this on your own is just focusing on how you can calm your brain throughout the day, add some kind of a meditation practice, focus on your sleep, and look a little bit at the timing of your meals, alcohol and caffeine. And I would probably start there. So
yeah, and what you're eating at your meals, because just like insulin, if you're eating lots of sugar or other things, or cortisol, you're spiking with inflammation. And so our bodies aren't supposed to be running from the tiger all day. And I think as women, we put our suit of armor on and we run from the tiger all day, and we can do it for a really, really long time. But once you've gotten to the stage that you're talking about, where you actually have a visit where they can't even make it all the way through, you're so far gone in adrenal fatigue. That's where what you do is you're keeping women from getting to that point. So just
Right.
because you haven't gotten to that point doesn't mean you're on the road there. And it's critical to take those key steps in the discipline to sleep, nutrition, timing,
Right.
all of that. So that's good. Thank you.
And that's a good lead into the insulin part of it. And in the true functional medicine, module, they don't even add insulin. I've kind of added that myself, but insulin, because when I talk about the things that affect cortisol, glycemic imbalance is one of the biggest things. So when you're consuming a lot of complex carbohydrates, and when I say that, I mean, all carbohydrates break down into simple sugars. Complex carbohydrates have a lot more work to do. Those are your starchy vegetables, your grains, your those primarily. And then fruits and vegetables are also carbohydrates, but they're very more nutrient dense. Your body doesn't have to go to work to break it down.
Right.
But when you are eating a lot of sugar or a lot of complex carbohydrates, your blood sugar is going to go higher. If you're not balancing that with healthy proteins and fats, it's going to drop lower. So you have this kind of peak trough that's just up and down all day long. And that's really stressing insulin, because your insulin is what's chasing down glucose to try to get it back under control. So the higher it peaks or it falls. And so when people get on this kind of roller coaster, when they hit those troughs, those low points, their brain is telling them, I need fast energy. And when people tell me I have a lot of cravings, I have a lot of sugar cravings, well, that's because your blood sugar's low and your brain is telling your body, I need fast energy. It's telling you what you need. However, what we do is we go after it with the quick fix. And so that's where this roller coaster begins. And now insulin is stressed.
Yep.
Well, insulin is stressed, cortisol is stressed. So you have to be a little cautious about the types of food choices you're making, and you have to always balance protein and fat with some plant-based carbohydrates. So that first meal of the day, breakfast, we check fasting blood sugar in the morning, because that's when our blood sugar is the lowest. So if you're going to get up and start facing the demands of the day, you need energy. And if you don't have that sustained blood sugar from the night before, that's just keeping it high enough, then you're going to need something for breakfast. Well, what is a typical breakfast for a lot of women? Cereal and milk, right?
Yeah, or dishing it out for the kids as they're trying to get on their way. So,
Right. Or just
granola
a glass of juice, a granola bar. Not really a good healthy protein, not really a good healthy fat. And so we have to look at breakfast, and and I that's usually the first meal that I talk about with people, the timing of it and what we're using at that time of the day. And we do a lot of troubleshooting with that meal first, because if you can start the day well, you've already gotten ahead of the game. But there's also trying to get people, like I said, not to eat too late. So if you're eating a quality breakfast, lunch, and dinner, you really don't need food between dinner and breakfast. And most people don't. Under certain conditions, maybe you do, but most people don't need to be eating anything between dinner and breakfast, and that will also help that sugar cycle that's going on throughout the day. So as I said, when there's glycemic imbalance or when insulin is stressed, then cortisol is stressed. So the next hormone down would be thyroid.
Can we just back up for a second? So going back to insulin. So in our last episode 6, we talked a little bit about the ketogenic diet. And, we've moved from grain-free to paleo to now keto and intermittent fasting. And women can treat that protocol any which way, so they cut out eating meals. So in that same reference, you're saying to cut out, the best meal to cut out is that kind of lunch and dinner meal, and have a good breakfast, fast, early dinner, fast, breakfast. Is that correct?
Oh, that's not what I was saying. No, I was talking dinner to breakfast.
Dinner
So
to breakfast. So after supper, your last meal of the day. See, some people say dinner, some people say supper. I grew up in Southwest Minnesota. I grew up on a farm. I don't know where you grew up, but so the last meal of the day
Yeah.
to
So
breakfast, you want to fast.
yes.
Correct. Okay.
Correct.
Just wanted to make
No,
sure that was clear because.
yep. Yep. No, you're right. No,
Okay.
and yeah, there are many different ways to do intermittent fasting, and that's a conversation because there are certain people that shouldn't do that, and there are certain people that might benefit from it, and there's lots of different ways to do it. So that's a whole
Totally
different
agree.
yeah. So thyroid. So thyroid, it's an interesting hormone because when people come to see me, they've already had the primary care visit where they've had their TSH checked off and their T4, and they're told everything looks fine. And they come in and they're like, I'm having all the symptoms. Most of the time, what I say to those patients is, you don't have thyroid disease. You have thyroid function.
Right.
And what conventional doctor is ruling out is thyroid disease. So if you go through those thyroid labs, the TSH is thyroid stimulating hormone. It's the body telling the brain, ramp it up or slow it down. So if your TSH is up, you're a little more hypothyroid. If your TSH is down, you're a little more hyperthyroid.
Right.
But that's not even a thyroid hormone. That's actually a pituitary hormone telling your thyroid gland what to do. So,
and that goes back to the metabolism that we talked about, so how do you,
right.
and how do you metabolize?
So now your brain is telling your thyroid gland, which predominantly makes T4. And T4 is about 90% of your overall thyroid hormone, but really only about 10% of the activity. But there's several things that affect production. And this is where we get into production, transport, sensitivity, and detoxification of these hormones. But production of thyroid hormones predominantly happens in the thyroid gland, and it's very dependent on things like iron. So women who have heavy menstrual cycles and have low iron, it's very dependent on iodine, which we live in the Midwest, and we don't have a very iodine-rich soil here.
Yep.
Things like zinc, things like vitamin D, vitamin C, specific B vitamins, vitamin A, they're all very important in production. So if you're deficient in those nutrients, you might be a little sluggish in production. And when I talk about reference ranges, yes, there's normal reference ranges. So if you have very low T4 and a very high TSH, yeah, you probably have some early thyroid disease, but maybe your TSH is just a little high normal and your T4 is just a little low normal. That we can address nutritionally. Other factors that affect production are going to be things like food sensitivities and heavy metal, and believe it or not, fluoride, which fluoride binds with iodine. So when we get our dental visit every 6 months and they give you fluoride, or you have fluoride in your water and you have fluoride in your toothpaste, that's affecting your iodine level. The other thing is just stress, and that's the cortisol connection again. So production then leads to conversion to T3, and T3 is not very predominant in the thyroid gland, but it's very predominant in the tissues.
Okay.
And you convert that T4 into T3, and that's very dependent on zinc and selenium. Selenium is very rich in Brazil nuts, which, all of my patients now, I tell them, if you eat one Brazil nut, you're getting 100 micrograms of selenium.
And that's what's so incredible is that on the nutrient piece of that, the how minimal Brazil nuts you actually need to get that selenium uptake. Same with, shiitake, or doing your, your spirulina, or your, your iodine sources. Minimal, but just getting that little bit in is a huge support to the thyroid conversion.
Correct. Yeah, no, that alone can make a big difference. And zinc, we get that from a lot of nuts as well.
Right.
A lot of good sources of zinc, but, making that quick gut connection, many of us have low stomach acid, and you have to have stomach acid in order to absorb those minerals. So if a woman has low stomach acid and they're cycling or having heavy menstrual cycles, and maybe their diet isn't that great, you're already lacking the minerals you need to not only make thyroid hormone, but to convert it to T3 in that active form. So there's another pathway that we don't often talk about, and that's reverse T3.
Mm-hmm.
T4 can go down one of two pathways, T3, which is where we want it to go, and reverse T3. And there's a purpose for that. I mean, we always, like we talk about good and bad cholesterol, when LDL cholesterol isn't really bad. Having the reverse T3 sounds like a bad thing, but it's there for the purpose of if you live in the Arctic Circle and your calories change in the winter, or if you are in a period of famine, if you look historically,
Yeah.
people
Storage.
who people who have cycling dietary changes are going to have the need to have the reverse T3 rise. It protects you and it helps you survive.
Mm-hmm.
So however, reverse T3 is also affected by things like the same things I mentioned with cortisol: infection, inflammation, food sensitivities, liver kidney dysfunction, detox issues, certain medications, and amazingly, even too much estrogen in the system can also increase reverse T3. So if you have this reverse T3 hormone, this inactive hormone, and this T3 hormone, which is your very active thyroid hormone, and they're all fighting to get in the same tissue receptors. If your reverse T3 is high, who wins? Now,
Mm-hmm.
that's a functional hypothyroid situation. That person doesn't need thyroid hormone. They're making it, they're converting it. They're just having a hard time getting into the cells because reverse T3 is blocking it. So now you're dealing with a physical issue. You're not dealing with, I need thyroid replacement. And so that's also a big discussion I have with patients. And I always look at all four of those thyroid hormones. And I also look at antibodies, which is a completely different subject. But that's not really, autoimmune thyroid issues are related to an immune system issue,
Yeah.
not necessarily a thyroid issue. The thyroid is just who's taking the heat as the result of the immune system issue. But
So with the immune system, the epidemic of women suffering from autoimmune issues on a percentage, where do you see women coming in with an autoimmune corollary, or a straight up thyroid issue? Like where do you see that balance? Because I believe that autoimmune is oftentimes connected to it.
yeah, I mean, I always the first time check the antibodies
Yep.
regardless. And I say half the time the antibodies for thyroid are fine. That doesn't necessarily mean you don't have an autoimmune issue. It just might mean it's affecting another system. Maybe you have
Mhm.
psoriasis, but your thyroid antibodies are normal. That just means this hyper alert immune system is affecting the skin and not the thyroid.
Right. Right.
So, there are a lot of women who still have autoimmune conditions but don't have thyroid antibodies. But those that do have thyroid antibodies, I have to say, usually they're many of them are already on thyroid replacement. They're just still having symptoms, and oftentimes I find that they're having a lot of gut issues
Yep.
or they have other diagnosed autoimmune conditions. And so we immediately know we're focusing on the immune system more than we are the thyroid. We're just supporting the thyroid. We're not really making that the center of our attention. So, but one thing I learned in functional medicine, it's something they really drill hard, is if you have somebody that comes in and they have thyroid dysfunction and you are at a point where they do need some support, a hormone support, if you do that and you don't address the adrenals first, you're actually going to make them feel worse. So might feel better for a little while and then things are going to go backwards. And that doesn't necessarily mean more thyroid hormone. That means you really got to take a step back and you got to start with the adrenals. So when I deal with thyroid issues, I'm always dealing with adrenal issues at the same time or even
Mhm.
first. So I'll look at both. I won't typically do thyroid testing unless we're looking at the adrenals at the same time or doing something to treat the adrenals at the same
Okay.
time. So, and then lastly, that gets us down to the sex steroid. And this is where, there are so many ways to intervene. And so somebody who comes in and they think that they're having, I think my hormones are out of balance. First of all, you have to look historically all the way back to when you first got your period. What was that like? Did you have a lot of problems as a teenager with your periods? Did you have a lot of symptoms? Did you have symptoms in your later years? And you have to kind of go through those transitions of time. Um, the issues with sex steroids is we're talking now about a whole new, set of hormones.
Mhm.
We're talking about progesterone, we're talking about pregnenolone, we're talking about, testosterone, DHEA, androsterone, estradiol, estriol, estrone. I mean, now it gets kind of complicated. And without going into a whole, lesson on on all of the hormones, um, for people that have, I want to just talk about two different imbalances. When we talk about hormone balance, we talk about progesterone and estrogen predominantly or primarily. Progesterone is a precursor in the pathways of production to cortisol. So when there's a high demand for cortisol, the first hormone that's going to be impacted is going to be progesterone.
Mm-hmm.
So if progesterone is getting sucked into the cortisol pathway, which we call progesterone steal, you're going to have symptoms very similar to what you feel when you're anxious. Brain fog, muscle tension, anxiety, insomnia. That's how people feel when they're under heavy duty stress. That's also how people feel when they have a progesterone deficiency, in addition to maybe having heavier periods, maybe having headaches, things like that.
Mm-hmm.
So that's the first hormone. And, when we talk about that imbalance, well, now you're progesterone deficient, which also means you're estrogen dominant, right? Because
Mm-hmm.
estrogen's up here, but your progesterone came down. However, in that situation, your goal is to try to get progesterone back up
Right.
by working cortisol. So that's one way of having that typical hormone imbalance. The other way is, as we get towards the end of these pathways, we make estrogen and we have to send it through these detoxification pathways when we're done using it, so we can transform it and eliminate it from the body.
Mm-hmm.
And that's a detox issue. And when we're not doing that well, we start holding on to estrogen, and it starts, if we can't convert that fat soluble molecule back into a water soluble molecule, it has no place to go but store in the fat.
Right.
And so now we become estrogen dominant. Now, if you have that estrogen dominance because of the detox issue, there's no benefit to giving progesterone to bring it up to meet a high estrogen. So you have to determine that where that imbalance lies. Is it a progesterone deficiency or an estrogen excess, or is it both? And you need to focus and bring them both back into balance. So women who have those typical estrogen excess symptoms like acne and they're more agitated, they're less anxious, they're more agitated. They tend to have a lot more headaches. They have, a lot more weight gain around, often more around the hips and the thighs, but it can happen around the abdomen as well. But when you start to see those kind of, and this is where we get the heavy periods and the breast tenderness, et cetera, et cetera. And so those women really have to look, number one, at where are they getting that estrogen from environmentally. We've all heard of, many people have not heard of the xenoestrogens, but those are those chemical estrogens in the environment. There's actually a really good, and I send this link to my patients, but there's a really great link on the Environmental Working Group website.
Mm-hmm.
If you go to that website and you type in endocrine disruptors, you're going to get a whole list of where are we getting these chemicals from. And as you know, it comes from hair care products, skincare products, lotions, cosmetics, lipsticks.
Yeah,
I mean, everything
definitely.
that has and I'm sure you speak to that a lot, but also plastics.
Yep.
And chemicals that we spray on our food,
Yep.
atrazine for those golfers, that are out there on the golf course that get sprayed on Monday and you're golfing on
Yeah, it's
Tuesday.
really interesting. I'll have more women talk about, like, just this last Saturday, I had a client just like so furious with her husband because he was putting, all these chemicals on the lawn. So she's like, well, the dogs walk through it, they bring it in the house, and it's taken her 5 years to like hide all of his obsessive compulsive, we need to have our lawn perfect chemicals to release that from his, ADD, to avoid that. Now, even when I formulate, beauty products, that is actually even, 8 years ago, something that I was really, really aware of is the xenoestrogens, because just as CBD and nano CBD can store in the tissue, just as is any other chemical. And, I have issue with all of the blogs, all of the health coaches that just want to put people through a quick and dirty detox, because this ends up to be a really, really dangerous situation where you just start dumping,
Mhm.
xenoestrogens or toxins from the body, heavy metals. And then again, I mean, there's so many like stop gaps that make women feel worse when they're trying to do this on their own. And
Right.
they don't, like you were talking about, is it an excess or a deficiency issue? Is it a progesterone or an estrogen? It's not like you have no estrogen, it's they're imbalanced, and what's appropriate for your age and where should those be balanced at. So there's so many nuances to it. But cleaning up the exposome and the environment is probably the most control and easy thing that you could possibly do as far as what's around you and what you put in your mouth. And that, I believe, probably resolves, if not
Yeah.
maybe 60% of it in itself, right?
Right. And then the question is, how do you start working on, and at that point, you can start safely working on elimination, whether it's
Mhm.
just beginning by doing it through diet. But
Right.
one story I had, I would say I do testing to look at how we metabolize estrogen. And one time I did that test on a young girl who was having a lot of heavy periods, a lot of anxiety, weight gain issues, and she was a dancer,
Mm.
on a dance line in college. And I did a urine test on her to look at estrogen metabolism, and it was probably one of the most elevated, we call it 4-hydroxyestrone levels I've ever seen.
Right.
Um, and that was probably mostly coming from the fake spray on tan, from the hair care and skin care, the products that they were using, and has been for years, because she didn't just get on a college dance line because she started in college. She's been doing this her whole life, right through puberty. So
Isn't
she's
that
been
interesting? That is
chemical.
really, really interesting.
And you know what? Fast forward. She's now become, now that she's several years down the road, she's really taken an interest in it and has really changed her diet and her lifestyle and her products, just for the sake of trying to be healthier. And it's really,
Yeah.
she finds is drinking the Kool-Aid, as you say. I
Mhm.
mean, she really is feeling significantly better. She's thinking more clearly. She's less dependent on medications. So anyway, it makes a huge difference. So first step is just getting rid of those things. You can't get rid of everything in the environment, but it's kind of like a bucket of water. If
Yeah,
you get rid of, 3/4 of that bucket, you're
right.
already making huge progress.
Yeah, I give
So
the analogy to a bathtub. If you're sitting in your bathtub and you're filling up your bathtub and, you know, you don't release the valve and you continue to pour water in, it's just going to get worse and worse. Um, can you speak to a little bit of a higher level between the three different pathways and how important the liver is as far as detoxification between the 2, the 4, and the 16 hydroxy pathway? And I only want you to bring this up because this is actually a key marker that we look for when we're doing hormone testing. And going back to this issue is, I'm not going to start detoxing you unless I know that you're efficiently getting rid of toxins. Otherwise, we just fill that bathwater of toxins back up, and with them nowhere to go, you end up
right.
with headaches, fatigue, and bloatiness. So, could you speak to the 2, 4, and 16?
Yeah, and actually, and those are actually phase one pathways. We have multiple detox pathways,
Right.
even beyond the ones we use in hormones. And so, but in the case of hormones, estrogen, we think of estrogen as estradiol. Estradiol is what premenopausal women are cycling, with menstrual cycles. But postmenopause, we predominantly make estrone. So estrone and estradiol have the ability to interconvert back and forth. But it all converts back to estrone, and then it starts heading down these detox pathways. And I like to call them the good, the bad, and the ugly.
Hmm.
The good
I like that.
pathway is a 2-hydroxy. Yeah, the good, and we like to see most estrogen being metabolized down that 2-hydroxy pathway,
Right.
and that creates that molecule into, again, it's turning into a fat soluble molecule. So just getting to 2-hydroxyestrone is not, we're not done there. Now it has to methylate into a water soluble form, so we can now excrete that from the body, poop, pee, or sweat it out.
Mhm.
Most common. um, so that pathway, I mean, we can measure we can measure the phase 1 metabolite, which is the 2-hydroxyestrone, and then we can measure the phase 2 metabolite, which is a 2-methoxyestrone. And so that's really the healthy pathway that we're looking for. So we're looking at 2 phases of that. The bad pathway is the 16-hydroxyestrone pathway. And that one, there's been a lot of data in the past on the 2:16 ratio, and looking at that 2:16 ratio, we really want to be more predominant in the 2 than the 16 pathway. The big one, though, the ugly one, is the 4-hydroxyestrone pathway. And that's one that I think we're learning more about all the time. But that pathway creates a more active estrogen molecule. And so the phase 1 end of that is 4-hydroxyestrone, and then that has to go through a phase 2 pathway too, and that's also dependent on methylation meaning your B vitamins typically, among other things. And then there's a glutathione pathway, and glutathione is kind of that really, really important antioxidant. It's also affected by selenium. It's also affected by vitamin C, something called N-acetylcysteine. But all of those, when you think of all of those colors in your diet, that rainbow of foods, your green tea, when we talk about antioxidants, we think glutathione. And
Yeah,
so,
we even talk about, H2 water and just how the molecular hydrogen water is the smallest nanometer of hydrogen antioxidant in the world. And that even can help, it doesn't have to always, what you're saying is
Mhm.
these antioxidants from fruits and vegetables and all of these other sources are what help the body elevate its own antioxidant levels of glutathione to help and assist the body. So it's really efficient that you can get all of those support agents to help the body raise its own glutathione for
Right.
detoxification and methylation. And
Yeah, the glutathione pathway affects more than just hormones. I mean,
yeah,
people that have glutathione, those are the ones that really, they're way more prone to getting lung cancer from, being
mhm,
exposed to cigarette smoke. They don't detoxify even environmental chemicals, exhaust fumes well. I mean, there's a lot of things that, those are the people that often say they don't tolerate a lot of things, but
right.
that can be genetically linked as well, which is a whole nother topic. But how do we, if we have, an abundance of 4-hydroxyestrones and they're not getting into that second phase and excreted from the body, how do we shift those back to that 2-hydroxy pathway? And that's something that I test for, and then we discuss what those results look like and what are some interventions that we can do to shift things back. Now, many people come in and they've already started to add things to their, supplement program, but not everybody needs, work at each of these steps. So, I really love the Dutch test because it can give me all this information and really help tailor that intervention to specifically what you need.
Yeah, but it never hurts to eat a little more broccoli.
Yeah, the first vegetables. I mean, you really should get something in your diet every day. And I've even had people, again, they read on the internet, so they find out, oh, I read that if you have too many cruciferous vegetables, it's bad for your thyroid. Well, no, too
Yeah,
much of anything is bad for something. So it's all about balance. But you
right.
really need to get those crucifers in your diet, in order to help with these hormone pathways. But if there's genetic correlations, you might need more than that.
Yeah.
So,
And even it's important for young women. I mean, you just think about going back to the dancer that you were talking about, you know, you and I are a little bit older. And so even as mothers, we should be encouraging our kids. I mean, these girls are getting, just flooded with hormones. And so
yeah,
it's really important to put these food items into their diet and really encourage that too at a very, very young age and get them ahead of
right.
the curve as far as detoxing all of this crap in
Mhm.
our environment that we're inundated with. So it's good.
Yeah. Yeah. One other thing, as part of this that I wanted to talk about, because I see this a lot, is the women that come in perimenopause and they are having the really heavy periods. And that's a not so uncommon thing that happens usually in the 5 or so years before, menopause hits. And, the heavy, frequent periods, and women will just say, you know what, I, I, I'm trying to decide if I should get a uterine ablation,
Mm.
because, or maybe a hysterectomy.
Okay, so let's do some vocab and let's talk about what is a uterine ablation so that everybody understands.
A uterine A uterine ablation is where it's basically, kind of think of it as they're lasering off the interior lining of the uterus to prevent that increase of, um,
Lining.
a normal menstrual cycle will create that thick estrogen, created rich lining so a follicle can come in or an embryo can come in and implant. We're basically kind of stopping that from happening. So ideally, when a woman is done with that procedure, she's not going to bleed anymore. She's
Mm.
still ovulating. She's still probably releasing that follicle, but there's no place for it to go. So it's basically a way to just stop that heavy flow. Now, what I hear often is some women will have done this procedure, but they'll say, "Oh, I still spot every month," or "I still have symptoms every month." What's just happened is you've gotten rid of a symptom.
Mhm.
Your problem is you have estrogen metabolism issues. You have that imbalance of estrogen and progesterone, where your progesterone is too low and your estrogen is too high. And or maybe just your estrogen is too high. But if that's happening, you haven't fixed the problem. You still are making excess estrogen. You're just not having a thick endometrial lining that's sloughing every month that's causing you to bleed heavy. So when people do that, and or some their full period comes back after several years, okay, that's a really bad sign. Right? Because you have some pretty significant estrogen metabolism issues. They fixed your symptom, but they didn't fix the cause of the problem.
Yeah, you get online and you start to type in, why am I still spotting after having this surgery? And the spotting issue for women is very, very annoying. And really sucks after you go through that step
Right.
and then have this return. Then how about, what are your thoughts on total removal and having a
Well,
hysterectomy?
so the hysterectomy, if you're having a hysterectomy, you just had your uterus removed.
Yep.
Um, Oophorectomy is when they remove the ovaries, and usually ovaries aren't removed in that situation unless you've had a lot of ovarian cysts.
Right.
Ovarian cysts are, they can rupture and be very painful, and sometimes people are talked into the oophorectomy because of one or both ovaries, just because of some of these other complications. Again, it's
Mhm.
fixing a symptom, it's not fixing the cause of the problem. But when you remove the ovaries, now you're in full-blown menopause, and you're going to have, and it's a surgical removal. You're going to have quick, abrupt symptoms, and oftentimes they're replacing back now hormone, whether it's synthetic or bioidentical.
Mhm.
Those hormones are getting replaced. So, that's one situation. But even women who have, if you are in your mid or early 40s and you have a hysterectomy, but your ovaries remain, many women will come in and they'll say, "Oh, but I still have my ovaries."
Yeah.
There's even been some data that shows that women that after a tubal ligation, it affects the blood flow.
Mhm.
So your ovaries aren't getting the same amount of blood flow because those procedures do affect how the blood flows to your ovaries. So you probably enter menopause earlier than you would have without the surgery.
Yeah, we're all connected. You can't lacerate the stuff out and expect
Right.
things to run the same. And I've also heard a lot of studies of increased cancer. There's an increase of dramatic depression for women after getting a hysterectomy. So I
Mhm.
understand the hurt, the pain, and the why women are drawn to wanting to do a hysterectomy when you're in so much pain and you've done numerous surgeries to mitigate it. But, if we can catch this early up enough along, ahead of the game and kind of correct these things through diet and everything we've just talked about,
Yeah.
there is a chance and there is hope for women to work with someone like you to correct that before it gets to that level.
Right. Right. And I think you have to, and if that is, I mean, if you're at the point where your life just can't survive.
Right.
Some women say, "I'm a teacher. I stand up there. I have to run to the
Right.
bathroom, the classroom." I've heard all the stories, and
Yep.
if you have to do it, but go into it knowing what your options are to treat yourself after, and
Mhm.
go into it knowing that just because you're not having heavy bleeding anymore, you're not out of the woods. So you want to keep um, addressing those imbalances and make sure that you're putting yourself in a safe position for the future. So um, yeah, so that is a kind of a big that is a big issue for many women. I do see a lot of women that come in. Many have had the surgery and they just want to have hormone replacement post surgically. and they want to use bioidentical hormones, as opposed to a lot of the synthetic stuff. And that's a whole um, that's a whole different topic. And I don't know if we want to get into that today, but the whole bioidentical versus synthetic hormones.
Let's just do a quick debrief on it. I think a lot of women wonder who to go to, etc. So let's just set up, bioidentical versus HRT. What's the difference and the plus and the minus of both? And
So HRT is hormone replacement therapy. It
Mhm.
basically means we're replacing hormones, when you're not making them on your own, either because you're not producing them anymore or because you've had surgery. Um, there's a whole,
Synthetically.
yeah. So there's a whole, controversy about the term bioidentical. And I even hear it with some integrative providers that say, bioidentical is a marketing term and it's just used to sell this different type of hormone, which is not necessarily safer than the synthetic forms. And, my challenge to that is, I still use the term bioidentical because what it actually means is that from a molecular structure, the hormones that you're taking from an outside source are molecularly the same as what your body would produce on its own.
Right. So another word for that is biomimetic. So the whole purpose is, same thing that we use topically on our skincare products, same thing you're going to use internally. You want the body to read it as though it really is what the body would originally be. So it's safer. It's,
Well, you have to be careful when you say safer because
well,
if you're not responding to your own hormones safely, you won't respond to these safely.
true.
So when people take bioidentical hormones and they say, "Will this give me cancer? Is this safer?" What I have to say is, well, let's talk about your own hormone history. If you haven't tolerated hormones well, or you have had hormone issues your whole life, we're just giving you more hormones.
Right, right, right.
Yeah, so we really have to be monitoring those metabolites, and
Yep.
can we manipulate those, and can we make it safer for you? But no, I can't promise that your body's not going to act inappropriately with bioidentical. They still can go down that 4-hydroxy pathway if
Right.
that's what you're typically doing.
Right.
So
So
you have
even testing while you get on bioidenticals and making sure the body is reacting and correlating with them correctly is huge.
correct. And so, bioidentical is just providing something that is the same as what you're, from a molecular standpoint, that your body has always made.
Right.
Um, Synthetic hormones, are the things that we often used in the birth control pill, or the most common ones that have been studied are Premarin, which is the one from horse urine. Most people know of Premarin, and Provera, which is the progestin. And progestin and progesterone are very dramatically different when you look at their molecular structure. And a lot of the issues with hormones have been because of that additional progestin. And so what the kind of conventional thought is if you don't have a uterus, we don't need to give you any progesterone or progestin because we're not concerned about uterine cancer, and therefore that progestin is only protecting you from getting uterine cancer. And so my thought is there's a lot of benefits of progesterone. We just talked about how it's a precursor to cortisol. So if you're lacking progesterone, I would still replace it, and I would never use a progestin. Very
Right.
different molecule.
So talking on the note of progesterone real quick. So, through Premier Research Labs and other ways and means, I have given progesterone to clients as, you can get it through YAM and do dabs half a teaspoon on the inner thigh or what have you. I find a lot of women try to shoot and aim with progesterone, taking a quiz online. How safe is it for women to just go and grab their progesterone? I mean, it's huge in the infertility industry, and it's also huge for, pre and perimenopausal women. What are your thoughts on that?
Infertility is a little different,
Yeah.
in how it's used, and they do use it appropriately.
Being able to carry the baby, increase of progesterone helps with that.
Yeah, it helps with that uterine lining, so you have a healthier environment for that embryo to implant. And so
Right.
some don't have that, and they need that localized progesterone in order to optimize that environment. And that's all used appropriately.
Right.
You have to be careful. Progesterone is, and I've learned this myself, it's not something you can just assume is a safe hormone. any hormone you give, like I said, progesterone's kind of at the early end of all of those sex steroid pathways. So if you give somebody progesterone, you have no idea where it's going to end up. It could end up as cortisol. It could end up as an androgen. It could affect your testosterone levels, which isn't a good thing if you have high androgen levels. It could actually dump into estrogen, and that estrogen might, not be safely metabolizing. So, a little bit of progesterone, you can still buy it, get it over the counter without a prescription, but I think you still have to be careful. It's a muscle relaxant, so to speak, in some respects. And so, some of the symptoms of getting too much progesterone are going to be things relax, like your joints, and you're going to have joint pain, or you could have, gallstones, right? Because your common bile duct relaxes. You could have more urinary loss. If you're somebody that has urinary incontinence, it can relax that sphincter, and you can have more urinary loss. It can also cause bloating and constipation. So you can't just give, if somebody already has natural excess progesterone, which is not common, but I have seen it, and you're giving progesterone, you can actually be making some symptoms that aren't expected.
Yeah.
Insulin resistance, high triglycerides, or some other things, mood changes. So you have to be careful. And I actually experienced a situation too where it affected the muscle recovery post-exercise. So, when you're doing high intensity interval training and your heart rate goes up, that's a smooth muscle, and
Right.
the heart rate wasn't coming back down.
Hmm.
And so the recovery of that heart rate on the low intervals was not recovering. And so the heart rate stayed high. And that was a
Really
progesterone.
interesting.
That was, a much higher dose. But you just have to be careful. It's still a hormone. And when you introduce a hormone, it's going to affect other hormones. So as
Yeah,
we
just as like a xenoestrogen is a mimicked hormone, slapping progesterone on your face to try to get the wrinkles to go away, or slapping it on your butt, all in
no,
the same, it can
it might be just fine, but it might not be.
affect you,
So
right?
you really need to know why you're doing it and how you're doing it, and if that's the right intervention for you. So
Yeah. So
I
let's jump into, let's kind of just dive and kind of bring some closure around, the sex steroids, because that's what women are most familiar with. And, let's just kind of walk through, early midlife and perimenopause, and what key hormonal quote unquote symptoms are usually related to the different phases of life, and then how we can support them
Mhm.
and close that up with our lifestyle.
So yeah, in midlife, you see a lot of different patterns. There's a lot of women that have been told they have PCOS, or polycystic ovarian syndrome. There's
Hmm.
various presentations of that. Sometimes it's high androgens, sometimes it's a lot of insulin resistance issues. Sometimes so the presentation is very, very different. But that, to me, when people have that kind of situation and they have infertility, or that situation and they have weight gain, you have to really kind of jump in deep, from my perspective, and really kind of weed out what is the true imbalance there. And that gets a little more complicated. Another one is postpartum depression. And oftentimes I find that's associated with a progesterone deficiency. And postpartum, when those hormones levels drop so rapidly, if you were somebody that already had some progesterone deficiency symptoms going into pregnancy, that abrupt change can sometimes elicit some pretty strong emotional changes.
Yeah.
Um, and then we talked a lot about the cortisol and thyroid related imbalances. And there's a huge connection to cortisol and thyroid imbalances and menstrual irregularities. So that's going to affect fertility. It's going to affect cycle regularity. It might affect your response to being on a birth control pill. So there's a lot of associations with that. So I do get a lot of people that come in and they just kind of want the deeper look at their hormones because they're having fertility issues. And I'm not a fertility specialist. I don't treat fertility, but I do try to try to get women in their best health before they become pregnant. Because, even if you're having detox issues,
Right.
there's significant concerns about that, even that are associated with breastfeeding. So
Yep.
you really want to be conscious of hormone health in those mid years when you're getting pregnant. In perimenopause, and perimenopause can happen even in the mid 30s. And that's, typically progesterone levels will decline before estrogen. And that's where we start seeing a lot of those estrogen dominance issues.
Mm-hmm.
More migraine headaches, more anxiety, and there's a lot of cortisol effects at that time as well.
Weight gain, hello, fat
Kids,
around the midsection, can't get rid of my fat,
a lot of
agitated.
people, the last, will say, I never was able to lose the baby weight after my last pregnancy. And,
Right.
and then kind of struggled. And obviously you have sleep deprivation, your life gets more stressful. Are you working at the same time? Your kids are growing up. So there's a lot of cortisol that influences there. But this is the age when you see the ablations and the hysterectomies, which fix the symptoms and not the cause. And that now also has accelerated your timing of menopause, which we also already talked about.
Mm-hmm.
And then menopause, that's a natural transition for women. And I mentioned this to my patients several times. You have to look at menopause as maybe this is normal for women, these low hormone levels. It was normal before puberty. Maybe we're just a little hormone toxic in 20s, 30s, and 40s for the sake of having babies. And now we're kind of coming back into the norm. But it's also a time when you transition from having these high hormone levels into these lower hormone levels. And when the ovaries stop making hormones, the adrenal glands are where it takes over. So now we're very dependent on that, healthy adrenals and cortisol production in order to make sex steroids efficiently. So when the sex steroid hormones start dropping because of the loss of ovarian function, you're going to see that big dependence on those adrenals. And this is where some women, you hear some women that say, I really didn't have a big, transition issue. I skipped a couple of cycles. I had a couple of hot flashes and, I feel great. These are probably the people that, number one, maybe genetically they're doing well, but they probably are exercising. They have a much healthier diet.
Right.
They probably are managing their stress much better. They're calmer people. They've kind of spent most of their lives not getting too overly excited about things. And they tend to respond much better to that transition than the woman who is totally stressed out by her family, and her extended family is causing her problems, and now she's got problems at work, and her marriage is starting to struggle, and now she's going through menopause. Well, you don't have a lot of reserve anymore. You just lost your biggest source of production for sex steroids. So those are the women where, number one, they really need to work from the top down, but then they're also the ones that they're functioning worse because of the loss of those sex steroids. And they're probably great candidates for some bioidentical hormone replacement. And so, when those symptoms are affecting your life, that's definitely an option. Now, if you get through that transition and you're really not having a lot of the other symptoms of menopause, but you have really severe vaginal dryness, and now you're starting to have a lot of pain with intercourse, and these women will often come in saying that their libido is low, but what's really going on is, okay, the lubrication is just not working anymore. And I would use lubricants, but it used to work and it's not. Estriol is that kind of third estrogen, and it can work great. DHEA can also work great used vaginally for tissue health. And some women, will say, even as they get older, they'll say, oh, I'm not having sex anymore, so it doesn't really matter. Well, it does, because if you have tissue breakdown in the vaginal tract, it's also happening in your urinary tract. And that's how come so many elderly women get urinary tract infections. You don't have that protective layer in the urinary tract, and women have a very short urinary tract. So that protective mucous membrane layer that you used to have in the vagina and now is gone, that's also happened in the urinary tract. So even just, and you can't, it doesn't mean you're not wiping correctly. We all have E. coli on our bottoms. It's just never been able to work its way up into the bladder, but now it can. So you
That
have,
is really interesting. That's
yeah,
really, really interesting. I mean, how many elderly women do we know that have repetitive issues with bladder infections?
right,
And
right.
so
And
this is lack of just, manipulation and health of the, vaginal lighting, which then also replicates what's going on further up into the uterine.
right.
So how do women correct that? Because just rubbing lube on it,
No, No, that's not going to help in the urinary tract. But that's why I say if you if you used to have that vaginal dryness and you with intercourse, just because you're not having intercourse now doesn't mean you stop treating those tissues. It means that you probably need to continue to treat those tissues, whether it's just once a week or once a month.
So how do you treat the tissue?
With a vaginal estriol or something like a vaginal DHEA. So you're
Okay,
using,
so the key is the DHEA or the estriol to make sure that you're okay.
and
Okay.
I use estradiol has been used, most often and still is conventionally. Estrace
Yeah.
is one of the common options, but I like the estriol better because it doesn't seem to have as strong of effect on the uterine lining if you have a uterus.
Now you can often find over-the-counter DHEA and things of that nature,
No,
abracadabra
but
and all of that. Is that the same?
yeah, no, I'm talking, well, you probably could. I don't know if it would work as well, but no, it's usually in kind of a base.
So you have to get a bioidentical cream and or mixture from a functional medicine provider like you.
Right, right.
So, okay.
And yeah,
So don't crack open a DHEA supplement pill, throw it in
I've,
coconut and put it on your vagina.
you could certainly try it. It's not what I would recommend.
I just gave you a DIY of how to make sure that your vaginal health is good today and the rest of your life.
Yeah. So but that is, that is one of the more common symptoms. And some of my patients that are no longer on topical bioidentical
Yeah.
hormones they continue on vaginal estriol longer term. And I think the majority of my patients are using estriol, not DHEA. I only use that if the estriol isn't effective in
Now,
its
is the DHEA the precursor of the estriol or is it?
No, actually 16-hydroxyestrone is the precursor of estriol.
Yeah.
It's, think of estriol as it doesn't have to go through those metabolic pathways like estrone and estradiol, already a metabolite. So you
Okay.
excrete it, you excrete it. You don't have to worry about. Now, could you give somebody enough of it and trigger symptoms? Yeah, certainly you could. It still affects the estrogen receptors, but
Okay.
yeah, it's a little bit safer, and you get it through compounding pharmacies. So there's no pharmaceutical for estriol yet. But yeah, I mean, for those that, don't need the full hormone replacement therapy for other symptoms, but this is their only symptom, that's really a good way to go. And it's something you can use long term. Now, beyond those, early menopause, post-menopause years, when you have a lot of symptoms, there's a handful of people that they need more support longer term. You take them off their hormone replacement and they have continued bone loss. Well, my first question about that, if that were the case, would be, why are you still having bone loss? Your bone loss is typically going to happen in that first 5 to 10 years after menopause. So if you're 10 years past menopause and you're still breaking down bone too rapidly, we really need to be looking at your gut and your nutrition.
Definitely.
But sometimes we continue hormone replacement therapy for bone management. And then the other big one is brain function. There's
Mhm.
a handful of women that you take away their estrogen and their brains just start to fog up
Yeah,
and
definitely.
decline. And, there is lots of data that shows that if we can maintain healthy menopause, postmenopausal, not 30-year-old estrogen levels, but if you can maintain a woman's estrogen level in a healthy manner postmenopause, it does protect the brain.
Yeah.
But there's some that you take it away and they do fine. And there's some women you take it away and then you have to say, okay, risk benefit. I mean, yeah, long-term use of estrogen and keeping those estrogen levels a little higher, there might be some risk to it. But if it's affecting your brain function, then you have to decide from a risk benefit standpoint. Personally, I would protect my brain.
I would protect my brain as well. Yeah.
So, that's, that would be, those would be a couple of the long-term uses of hormone replacement therapy.
Yeah, and what I'm realizing is there's a lot of different ways that you can use, bioidentical hormones and how they
Mhm.
can be applied. So, we're just not going in and shooting and aiming and trying to sustain what we were before, but there's all different ways that they can be applied, how they can just kind of support us or nurture us just to kind of edge us along and really get us to feel optimal every day and make sure that we decrease issues longer down the road, before. What's also coming to mind is, we often attend to kind of want to get our arrow once we turn 40, and we muster up and we read all the blogs and we're like, okay, now I'm going to start going through menopause. What do I do? And, then we delay what we do until we actually start feeling the symptom. And what's so critical is that young women, and now that functional medicine has become somewhat norm, is that we now have access and tools and the knowledge as young women. And it's a shame that we don't really learn about our hormones even in high school, and how to appropriately take care of our hormone health from, teenage years, 20s, 30s, 40s. So we don't have to wait for these hardcore issues and then live our later years in life when we're supposed to be free, feeling great, experiencing great sex, all of those things. Now there's emotional components to that as well, but there's so much that we can do along the way, and grabbing someone like you as a functional medicine practitioner doesn't need to be the last ditch effort when all else has gone wrong and you've repetitively had normal quote unquote thyroid tests from the doctor. That this is actually a place to start. So one thing that, I often tell my clients is it's really actually wise to see where your hormones are functionally normal right now and grab a partner such as someone like you so that you can then have that biomarker. And then as you go through these transitions, make sure that you can then understand and look back and say, okay, that was right for me, because we're all individual, and then be able to balance that out and teeter it as we go along in life.
Right. Right. And I have some patients that I've been seeing for, 5 to 10 years, and I don't see them, several times a year. They checked in with me initially because of a thyroid issue, and, that's been maintained, and we're doing well there. And now they're hitting perimenopause. So we're checking in again, and then they hit postmenopause and we're checking in again. And, I've had people stop in and, check back in, 4 or 5 years later.
I love that.
Yeah, I just had a patient who I did treat for bioidenticals. She ended up, stopping them herself. She was changed her lifestyle. She was feeling great. She actually just came back for nutritional counseling. I just want to make sure I'm getting what I need to, stay healthy into my older years.
Mm-hmm.
So we're back looking at just some basic nutritional markers and getting her on just kind of a basic nutritional program with some dietary recommendations, and just, here's the, 2 or 3 small issues that she has, and how can we address those?
Yeah. So let's just jump into lifestyle then. Oh my gosh, I'm sure the women are like, their heads are spinning, right? So we talked about a lot. But let's jump into lifestyle, and then let's just kind of close this out. And then if there's any final thoughts that you would have based on your experience and then what we've already talked about today. So to reduce stress, obviously, is the number one thing all of us can do. Because if we go back to that top of the peak, that cortisol, that sleep-wake cycle, sleep is critical, and maintaining stress and the inflammation that it pushes out in the body. I mean, that's a frequency. Stress is a frequency. And even stressful thoughts release a frequency of toxicity into our endocrine system. So how we think, how we eat, how much we sleep. We talked about exercise and movement. Stagnancy is also psychosomatic, where we move. And, I think with exercise, correct me if I'm wrong, Julie, these hard HIT stressful exercises that women think they have to do to trick their metabolism to kick the fat out are sometimes not appropriate.
Not for everybody.
No, a long walk is stress reducing. It helps you connect your mind and your heart, and you just kind of release the stresses of the day. It's a great way to release stress through exercise.
You can actually, the high intensity interval training is kind of, there's one, we often think of it in one way, and that's the true high intensity. You can do the same thing if you go for a walk, and you get an interval timer on your phone, and you set it to give you an alarm every 3 minutes. And let's say you're doing a brisk walk, and every 3 minutes you jog for 30 seconds. That's high intensity interval training. It's basically changing your heart rate from high to low to high to low. And that there's actually some benefit in that. It doesn't have to be the intense boot camp workout.
Right. You don't have to kick your ass. We kick our asses in our own way as women in the way we think about ourselves. So be easy, be easy. And then we talked about mental and emotional stress, guided meditation, just how important it is to grab a CD. Some of the hypnosis CDs are really great, whatever you want to work on to sleep through those, even like the hertz. So the frequency and the beta theta CDs. So just getting into just that sound in the background can help your stress levels lower down. Relationships. In the first episode, we talked about how relationships can sabotage what we're trying to do with our health and how important it is. You recommended, you will see patients, but you often recommend them having a coach with them to kind of help them in their transitional changes and lifestyle changes.
Or even bring their spouse.
Mm-hmm.
It's amazing how often women go home and it's like, I tried to explain this all to my husband and he didn't understand and it wasn't making any sense. And I'll say, why don't you bring him along next time? And then frequently it's been very funny. Those women will say, my husband wants to know if he can schedule an appointment with you. And I have to say,
I love it.
women's health only. So
Yeah.
I can recommend a few people, but
For women, by women.
so sometimes the men need to come in to hear the same thing. And during our visits, they'll say, okay, so my cholesterol is a little high too. Would you suggest that for me?
Oh, I love that.
So I think that's for most women, if they're married, that's a big relationship. So you need that support. And if they're not supporting you through the journey of functional medicine, then bring them along. Let's get them educated. So
Okay, I can't not do this, Julie. Can you just let me? I have to read this poem because I think it's actually really hilarious. So talking about men and the phases of our cycle for men. So I'm going to read this right now. So one day a man found an old genie lamp in his yard. After turning it over several times, a genie popped out of the lamp and landed in front of the man. I'm an old genie, the genie said, so I'll grant you only one wish. The man thought for a while and said, I'd like a bridge from my garage to the Bahamas. A bridge to the garage to the Bahamas, the genie explained. I'm old. I can't make a bridge from your garage to the Bahamas. So the man thought for a few more minutes and said, okay, fine. I'd like to understand women. So the genie deliberately just sat there thinking for a long time, floating around and muttering to himself. Finally, he walked up to the man and said, okay, you want the bridge to have 2 lanes or 4 lanes? Bring your husband to your visit to Julie and she'll explain all the
or at least to the follow-up visit, and we can now have some objective information and some
right
exam findings that might help to support what she's been saying and her doctor has been saying is not really a concern. So yeah, that's when you talk about relationships, that's the big relationship piece is to have somebody in your life who supports you in this. And that sometimes when it comes to things like weight loss and making some significant changes, sometimes the husband has been the one encouraging them, but the woman doesn't, or the boyfriend or whatever, the partner doesn't want to see, they don't want to hear it from the closest person.
right
So in that case, a health coach can be very helpful, because now outside person with whom you don't have a relationship other than as a health coach, kind of putting things back in your face saying, yeah, I guess you're right. And you're not taking it personally. So yeah, relationships are a big important piece. One other thing I want to say about nutrition, and nutrition is a very wide topic, and everybody's nutritional recommendations are different from my perspective, but hydration is so important. And I'm finding more and more now about the studies on how women post-menopause need more fluids. And how many people have you heard say, I don't like water? So they're drinking other things. And but hydration is, it's not always just hormones that are affecting the wrinkles in your skin. It's that you're not hydrating. And so, yeah, I mean, nutrition and hydration is important, exercise and movement, and stress and relaxation, and those relationships. And yeah, I mean, if you can master what we call those modifiable lifestyle factors, you've probably cleared away a lot of the fog, and now you're really seeing what's left over.
Yeah. And the last was detoxification. That's the last piece that we didn't. And with relationships, we really have to look at everything in our lives and detox and pluck out the things at the root that we really have been entertaining and we know in our heart of hearts that need to go. So
Hmm.
that's a really holistic thing to really meditate on, and maybe grab a journal and really figure out what you need to detox from your life so that you can have more energy to focus on you and giving yourself the oxygen mask versus being the oxygen mask for everything else,
Hmm.
because that depletes your heart, soul, and your hormones.
Hmm.
So, well, Julie, I so appreciate you coming on today. Is there anything else that you want to share on this, like bloated? Don't mean to use that word, hello, estrogen, but anything else that you want to talk about this big subject today?
No, no, but I think just leading into another topic for next time, I think is, I mentioned that, the hormones are impacted by one another, but the hormones are impacted by every other system. And so we have to look at the hormones as the barometer in the middle. Um,
Mhm.
and um, so we have to, think about how the gut affects hormones, how the detox system affects hormones, how our immune system affects hormones, how, um, the cellular energy affects hormones. And so there's a lot of connectors there. And I think that's when you get past, or sometimes you have to start there when somebody comes in and it's a hormone issue and you say, yeah, you know what, I think it starts over here.
Right.
So I think look over here. So it can be a much bigger issue. And I think that's something to focus on for another
Yeah.
time.
Yeah, I think that's really great. So, really looking at your biomarkers that we talked about, but, I think you've mentioned it before.